Welcome back to The Explainer. Today, we're literally racing against the clock to unpack one of the absolute most critical, time-sensitive pediatric GI emergencies out there, biliary atresia. It's kind of like a medical mystery, right? You have a perfectly healthy newborn, and then suddenly their body just turns against its own anatomy. We're going to trace the entire clinical journey of this disease, from the cellular pathology all the way through to some really intense surgical treatments and post-op care. It's a fascinating but honestly terrifying condition, where catching it early literally means the difference between a high chance at a normal life and needing a massive organ transplant. Here's our clinical roadmap. We'll kick things off with the pathology, move into spotting those subtle clinical clues, and then sprint through the diagnostic race against time. After that, we'll break down the Kasai procedure. And finally, wrap up with the absolutely vital post-op care directives you've got to know.
All right, part 1, the pathology of biliary atresia. Let's dig in and figure out exactly what we're up against here.
So, biliary atresia, or extrahepatic biliary atresia, is pretty rare. It hits about 1 in 10,000 to 15,000 live births. Now, you won't see this every day in a general peds clinic, but because it is so devastating if you miss it, it has got to be high on your radar with every newborn. If left untreated, it predictably leads to cirrhosis, liver failure, and death for most kids by age 3. Why is it so predictable? Because the bile literally has nowhere to go. It backs up into the liver, acting like a severe toxin that just continuously scars the organ from the inside out. Here is the real kicker. This isn't just a simple anatomical roadblock or a tube that didn't form right. It's a relentless, progressive, inflammatory process. It attacks both the intrahepatic ducts, the ones deep inside the liver, and the extrahepatic ducts, causing severe fibrosis. Basically, the infant's body is turning functioning, necessary bile ducts into solid, useless fibrous tissue. The end result? Complete ductal obstruction. And the timeline playing out here is terrifyingly fast, which starts as a perfectly healthy-looking baby at birth, rapidly devolves into a crisis. We don't even know the exact cause. Maybe it's an immune response from a viral exposure or some other perinatal insult, but the acquired perinatal inflammation just aggressively takes over. By just 4 months of age, those once healthy bile ducts can completely disappear. They are just entirely replaced by fibrous tissue. Moving to part 2, spotting the clinical clues. Because this obliteration happens at lightning speed, our eyes are our absolute best line of defense. We cannot wait around for the liver to fail. You've got to look for a stark contrast in the diapers. Normally, you expect those typical mustard yellow or greenish stools and pale urine, right? But if you start seeing progressive acholic or gray putty-like stools, that is a massive red flag. It means absolutely zero bile pigment is reaching the gut. Combine those gray stools with unusually dark urine and jaundice that hangs around well beyond 2 weeks of age, especially if it's direct conjugated bilirubin that's elevated because the liver processed it but it's trapped. If you see that specific trio of symptoms, you need to suspect biliary atresia immediately. You'll likely also feel an enlarged, firm liver early on. All right, part 3. Once you spot those vital clues, the diagnostic race against time is officially on. Every single day counts now. The ticking clock here is a super strict 2-month window. We can often achieve successful biliary drainage if we intervene before those intrahepatic bile ducts are totally destroyed. If the definitive surgery happens before the infant hits that 60-day mark, the success rate for reestablishing bile flow is actually up to 90%. But if you delay past that window, those odds absolutely plummet, and a liver transplant becomes almost inevitable. This is exactly why newborn screening and hypervigilant parents in those first few weeks are quite literally life-saving. So we follow a really strict escalating diagnostic pathway. We start non-invasively with labs to check bilirubin and rule out torch infections, things like toxoplasmosis, rubella, or CMV, which can actually perfectly mimic these liver symptoms. Next up, an abdominal ultrasound to check for anatomical weirdness like a colodocal cyst. Then the HEDA scan. If there's no radioactive tracer making its way into the duodenum, biliary atresia is highly probable. Now, HEDA scans can take days, so a percutaneous liver biopsy is often done for rapid tissue evidence. But ultimately, the definitive diagnosis only happens in the OR during an exploratory laparotomy with an intraoperative cholangiogram. Section 4, the Kasai procedure and treatment. Now that we've confirmed the blockage in the OR, how do we actually intervene and save this kid's liver?
Obviously, surgery is the main event, but medical management is incredibly foundational. Because bile isn't reaching the gut, these infants are dealing with severe malabsorption. They need special infant formulas totally packed with medium-chain triglycerides, or MCTs, plus heavy supplementation of fat-soluble vitamins A, D, E, and K, iron, and zinc. And the med list is fascinating. We prescribe phenobarbital. Now, we aren't using it as a sedative here. We use it because it acts as a choleritic. It chemically kickstarts the liver to push out whatever bile it possibly can. We also use ursodeoxycholic acid to help drop the cholestasis and soothe that intense, agonizing itching caused by retained bile salts. Drawing straight from our pediatric critical care directives, if the infant is rapidly deteriorating, profoundly dehydrated, or prepping for surgery, we are admitting them for immediate IV fluid therapy. When the gut is compromised or we're gearing up for that exploratory lap, it is absolutely essential to maintain a strict NPO status, nothing by mouth. We've got to perfectly correct any fluid and electrolyte imbalances before they ever cross the threshold of the operating room. Enter the hero's intervention, the Kasai procedure, formerly known as a hepatic portoenterostomy. Think of this intricate surgery as completely bypassing the blocked plumbing. The surgeon removes those obliterated extrahepatic bile ducts entirely. Then they take a segment of the baby's own intestine to create a roux in wide jejunal limb. They pull this intestinal loop right up and attach it directly to the resected porta hepatis at the base of the liver. The goal? To catch bile draining from any microscopic, unscarred ducts right at the liver's surface, funneling it directly into the intestines while preventing intestinal contents from refluxing back up. But let's look at the reality of the Kasai procedure's outcomes, which are basically governed by this rule of thirds. After surgery, about 1/3 of infants hit the jackpot. They become jaundice-free and regain normal liver function. Another third will still sustain liver damage but can survive for a good chunk of time with heavy medical and nutritional support. And that final third? Unfortunately, they won't regain bile flow at all. They'll rapidly progress to end-stage liver disease and will absolutely require a liver transplant. So the Kasai is life-saving, but it's a treatment, not a guaranteed permanent cure. Which brings us to Part 5, Complications and Post-op Care. The heavy lifting really kicks in with long-term management and specialized nursing care. Even with a totally successful Kasai procedure, we have to stay incredibly vigilant. This new anatomy puts the child at huge risk for ascending cholangitis, which is basically an infection marching backward up the intestine directly into the liver. If the liver disease progresses, you're looking at severe complications like portal hypertension. That can trigger massive GI bleeding from varices, those swollen, fragile veins in the esophagus. We also monitor for advancing cirrhosis, massive fluid buildup called ascites, and worsening pruritus. The itching can get so severe we have to use colloidal oatmeal baths and file their fingernails down so they don't literally tear their own skin apart. Your hands-on nursing directives here are rapid fire and absolutely vital for safety. Post-op, keep them NPO and strictly push those prophylactic antibiotics to block that ascending cholangitis. You've got to heavily monitor for aspiration and any vomiting. Document the exact content, amount, and crucially the color. We are hunting for the presence of bile or red blood. Maintain strict stool output measurements to verify the gut is working. But here is a golden rule. Absolutely nothing up the butt. No rectal temps, no suppositories whatsoever. Finally, meticulous skincare. Severe diarrhea often follows, so keep the area ultra clean, slather on thick barrier creams, and leave the skin open to air to heal. As we wrap up this explainer, I want to leave you with something to really think about. We know for a fact that the 2-month window dictates survival and liver preservation. Yet, in those first few weeks, these infants look completely, perfectly healthy. So how can we revolutionize our initial newborn screenings? Could we use universal stool color cards, or maybe early bilirubin fractionating to catch biliary atresia before that irreversible fibrosis even has a chance to begin? Just think about how one simple shift in early screening could literally alter the entire trajectory of a child's life. Thanks for hanging out with me for this explainer. See you next time.